Great. Okay. So good morning to anyone who's I've not met. My name is Alex Nissen. I'm one of the general surgery fourth year residents currently on the trauma service. And today I'm talking about really management for massive pulmonary embolism with a focus on surgical management, the discussion of submassive pulmonary embolism and catheter-directed therapy could be their own talks in and of themselves. We'll focus really on the scope of the disease. I will spend several slides, honestly, on the pathophysiology of particularly massive PE with some associated definitions just for clarity before we really jump into pertinent guidelines that come both from the American College of Chest Physicians. I think everyone is familiar with chest guidelines, but in the treatment of massive pulmonary embolism, probably the AHA and ESC guidelines, and then also these PERT guidelines from the PE response team, which is a new consortium that first put out this publication about 2019, are probably the most germane to today's discussion. There's a single slide on prognostication and then really focus on some surgical technique and the use of mechanical circulatory support and ECMO. So just starting broadly, obviously PE is a problem that afflicts a number of our patients. There's estimated to be anywhere from 100 to 180,000 deaths per year due to acute pulmonary embolus. It's routinely charted as the #1 preventable cause of death among hospitalized patients, both in the United States and worldwide, and then the #3 cause specifically of cardiovascular death. Massive PE does not make up a large percentage necessarily, but 5% is really not by any means negligible when we're considering patients that are floridly unstable at the time of their PE diagnosis, and submassive is another significant cohort, anywhere from 25 to 40%. With the images below taken from a recent publication essentially showing that recent rates of PE are rising, although mortality may be falling. We're not necessarily doing any better at preventing PEs. So specifically with regard to submassive and massive PE, what is really affecting the patient's physiology is primarily that they have an abrupt increase in their pulmonary vascular resistance. It's primarily really an obstructive process of the right ventricular outflow, and that obstructive process is really more acute, although I think frequently we probably talk more about hypoxia in PE patients. We're talking about submassive and massive PE. This is really a hemodynamic problem. They have this abrupt increase in RV afterload and abrupt RV dilation, as the right ventricle is really not meant for acute changes in pressure loading. That is followed by pretty prompt altered contractile ability of the RV with associated increased RV wall tension, which is the number one factor associated with myocardial oxygen demand. And thereafter, they have really right ventricular ischemia, because you not only change the supply demand matching of the RV, but the pressure will start to impair diastolic filling of the RV, or really of the RCA, to supply blood to the RV myocardium. With that, the RV will continue to dilate, and the contractile portion of the right ventricular systole will kind of spill over into what should be early diastole, and that's when you really start to see your septal bowing. At that point, you truly have a reduction in right-sided cardiac output, which generates a decrease in left ventricular preload and systemic cardiac output, after which patients are, systemically hypotensive. They have now frank biventricular ischemia because their left heart cannot adequately eject, and that's when it becomes manifest as shock. So the take-home point is really that everything I just discussed was purely hemodynamic. This is really not an acute hypoxia problem. And I think frequently we think about the need to intubate these patients and the need to control their airway, when in fact intubating a patient who's forwardly hemodynamically unstable from the standpoint of the right ventricle can be one of the most dangerous things that you could do to these patients. And so it's really important to consider their hemodynamics before doing anything that will affect their preload. And then also, there are multiple studies that show very clearly that there's no correlation with the anatomic thrombus burden in these patients, what it looks like on CT echo or anything, and the actual individual patient hemodynamics.
Really quick, I have a question.
Yes, sir.
So that would be slight news to me. So let me turn my camera. So Seattle 2, which I feel like you'll probably talk about, Seattle 2 trial.
I'm familiar with it, but I was going to skip over it. But yeah, because it's a little more of a submassive trial, and I wasn't going to talk a lot about catheter-directed therapy. But go ahead.
Well, I guess my question is, has that been debunked? Because that is really an anatomic discussion. The entire trial is based on measuring RV to LV ratio. Is that no?
So,
I'm asking. I don't know the answers. Is that no longer true? Did we?
so I think I may have been unclear. I may have been unclear. The anatomy of the embolus does not correlate with their hemodynamics. You can have someone with a saddle embolus and they can be asymptomatic. You can have someone with fairly peripheral but large emboli that's obstructing multiple segments, and they may be deemed to have a massive PE from a hemodynamic standpoint. The anatomy you're talking about of RV to LV ratios is still very much in use, especially when predicting RV failure. And Seattle 2, I talk a little bit about the Ultima trial later, but a number of these catheter-directed therapy trials focus on echocardiographic and hemodynamic endpoints rather than hard endpoints like mortality. That anatomy is still very pertinent, but looking at on CT and looking at this big saddle thrombus just because it looks big does not mean that this patient has a massive PE.
So I'll give you one just sort of bias that I will bring to the table when it comes to PE, and I don't know if Dr. Bowen feels differently, but I would agree with you that what you see on a CAT scan in isolation is not predictive of symptomatology or outcome. I will tell you that when you have a patient and you can take into account what you're seeing on CT and then look at a person like clinically, even if you don't know, like when you actually look at these people, and again, I'm talking about massive PE now, they look like they're about to die. And so what they look like is probably much worse, but there is a little bit of, I would call the art here, where you're trying to match, okay, is this person about to die? Are they just before that? And then what does their CAT scan look like? And I agree with you. Like if you look at the one in the middle, that patient has flow around the PE. And so
these
you
are all
might
the
actually,
same.
what's that?
They're all the same. These are all the same picture. That was kind of the point I was trying to highlight.
Right. And so my point is that you're right. You can't tell, but it's a little bit of I think going from the science of medicine to the art of medicine, and you're trying to decide who do I intervene on, because all the interventions are largely come with some risk.
Mm-hmm. Absolutely. And I think your point of kind of the gestalt and the way a massive PE patient looks very sick, I kind of skipped over a slide about diagnosis, because I think we all know that if a patient is stable enough to go to CT, you would get the CT-PE. If they're not, then your preferred first test would be an echo and lower extremity Dopplers. But the point being that, the diagnosis of submassive and massive is really based on hemodynamics. And like Dr. Proper was talking about, these patients look incredibly ill when they're diagnosed with a massive PE. The definitions for that are probably best spelled out in the AHA guidelines, where really a massive PE is someone who has hypotension with or without the need for vasopressors or associated bradycardia or other forms of shock. Submassive PE is someone who has evidence of either RV strain based on echo, which is well defined here, or the evidence of myocardial necrosis with an elevated troponin. And a non-massive PE or limited or subclinical PE would be someone who has a radiographic PE in the absence of symptoms or evidence of any RV strain. So this is additionally spelled out a little bit more clearly in some of the European guidelines. But again, I just want to really emphasize that the definitions of massive and submassive and low risk PE are totally based on hemodynamics. It's really not based on thrombus distribution. In terms of upfront treatment, there are some societal guidelines that are just not controversial at all. Obviously, upfront anticoagulation is very useful in these patients and can be started with even a reasonable suspicion of a PE if there may be any delay in diagnosis. That's really not an area of controversy at all. There are some useful scores for prognostication. I won't belabor this, but the PESI score or PE Severity Index is probably the score that you will see or read about most. It is actually incorporated into the European Society guidelines. And there are abbreviated forms of the PESI score, but it can be useful when prognosticating, especially within the submassive cohort, about patients who may be destined for worse and right heart failure and may benefit from upfront intervention as opposed to anticoagulation. So what I do really want to focus on, though, is the treatment and decision-making for massive. I think submassive is actually an area of greater controversy than massive PE. And massive PE is an area where you kind of have to know what's at your disposal early in order to make the appropriate plans for treatment for these patients. So obviously, once someone is systemically hypotense for greater than 15 minutes or requiring vasopressors or having profound bradycardia or other evidence of shock in the setting of a PE, they're highly unstable, and you really need to decide what's best for these patients? Do they need systemic thrombolysis? Are they best treated with a catheter-directed therapy, of which there are numerous options, or are they best treated with a surgical embolectomy? And so to start, we'll kind of go through the evidence for all three of those. Hopefully, I can show you that surgical embolectomy is a worthwhile consideration and can be a good operation for these patients. And then we'll talk some more about mechanical circulatory support. So systemic thrombolysis, really part of the reason it has a stronger grade of recommendation in some guidelines is because it actually has prospective randomized data. But when you look back, this is the only prospective randomized trial of systemic thrombolysis in massive PE. It involved 8 patients. Personally, I think this sounds kind of like research that I would do, but 4 patients got heparin and they all died. 4 patients got thrombolysis and they all lived. And so at an early interim analysis, it was deemed to no longer offer equipoise. So the trial was halted early. And so this is actually the trial upon which a lot of the recommendations for systemic thrombolysis are based. And I think it's worthwhile to note really just the very small N and kind of the quality of this trial. I mean, it's, I think, a 3-page manuscript in total. In terms of other larger registry data that does show any benefits for systemic thrombolysis, this is a chart that I think outlines probably best the trend towards a survival benefit for systemic thrombolysis in the setting primarily of massive PE patients over submassive PE patients, but also one always has to recognize kind of the inherent bias and the retrospective nature of registry data, selection biases, and why this is never going to be equivocal with prospective randomized data.
Hey, Alex, do you know what CHEST says? Do you know what CHEST says right now? What the recommendation for massive is for CHEST?
They say that you can consider systemic thrombolysis, but they actually don't really address catheter-directed therapy or surgical embolectomy. I'll show that recommendation a little later, but the AHA and European guidelines probably do a better job of outlining all three as opposed to just saying consider thrombolysis and kind of stopping there.
There's a discussion about, so when you're talking about systemic TPA administration, mm-hmm. One of the problems in the old CHEST guidelines was there were recommendations regarding catheter-directed thrombolysis or pulmonary embolectomy. Mm-hmm. And what that was leading to, some thought, I guess I should say, is delaying care, right? So if you were presented to a small emergency room and they didn't have those available, or even a mid-size, care was being withheld. So the new CHEST guidelines actually recommend almost against catheter-directed thrombolysis, largely because when the CHEST guidelines were written, it was not routinely available at most hospitals, including major large hospitals. I think in the last 2 years with the advent of PERT, that has really changed. Like, people have really taken this on, and I'll be surprised if the next CHEST guidelines don't actually have different recommendations. But the comment being that the current CHEST guidance recommend that if you think someone has a massive PE and you're thinking that they need catheter-directed lysis, the recommendation is actually for systemic TPA, 50 milligrams of systemic, or maybe it's 100. I can't remember the exact dose, but it's for systemic administration, knowing that you can kind of come back 45 minutes later and still do catheter-directed lysis. With that being said, I'm not sure that any cardiac surgeon would be really interested in taking a patient for sternotomy after getting 50 milligrams of TPA for multiple hours.
Yeah, that's a very good point. Thank you, sir. And I think the PERT guidelines probably, I'll talk about it a little bit more later, but it highlights probably the way that these are best treated with kind of a single consult to a service line that is a multidisciplinary team that's managing these patients. But so in terms of, so we've talked about some of the benefits of systemic thrombolysis. There are obviously drawbacks. This is a meta-analysis primarily involving systemic thrombolysis in both massive and submassive patients, but I would draw your attention really to the last 2 lines where you note that there is a benefit in terms of all-cause mortality, but with the number needed to treat that is about 3 times larger than your number needed to harm in terms of risk of major bleeding. And I think this has been part of the impetus that we all are aware of in terms of kind of moving the ball forward with catheter-directed either thrombolysis or thrombectomy or surgical embolectomy. These are a few of the guidelines that Dr. Proper was mentioning in terms of the actual dosing. In general, the safety of thrombolysis is much safer if it's 100 milligrams over just 2 hours as opposed to 24 hours. There is some additional data citing safety in patients that are high risk for complications of just giving 50 milligrams once. In terms of the chest guidelines, they also are quick to point out, there's a number of both major and relative contraindications to systemic thrombolysis, and it's particularly germane in surgical patients, which is primarily who we will be seeing in terms of who actually has a massive PE. And so these, will commonly come up, and they may actually be reasons that patients fall out of candidacy for treatment with systemic thrombolysis. So next is really kind of what do we?
Hey, Alex,
Yes, sir.
I mean, can you just kind of summarize, just so that it's clear in people's mind that, the branch point, the first decision I think you make with these patients is whether there is a contraindication for systemic thrombolysis or not, right? Would you agree with that from what you?
I would.
You read?
Yeah.
Okay, right. So, I just want to make that clear to everybody. And then the benefit would be, just to kind of summarize, it's potentially a mortality benefit with that compared to just regular anticoagulation, but you're buying a higher risk of extracranial bleeding and potentially hemorrhagic stroke with thrombolysis, correct?
Yes, sir.
Okay. I mean, just so that, because you kind of went through a lot of stuff, but just so that the junior folks kind of get the basic crux of the matter, is that I think that's the place you want to start with your decision making, is whether they have a contraindication or not for systemic thrombolysis. And then if they don't, then we kind of head down the path that you're taking us right now.
Yeah.
I mean, if they do, excuse me, then you head down this path.
So as Dr. Bowen was saying, for the sake of discussion, we'll consider, patients who do have contraindications to systemic lysis. When thinking about catheter-directed lysis, I think there are a number of options out there. Different options will be available at different facilities and based on differing levels of expertise, and whether you're speaking with vascular surgery, interventional cardiology, interventional radiology. This is a not completely inclusive, but a widely inclusive list of available options. It's important to consider, though, that the preponderance of data for catheter-directed thrombolysis is really in the submassive PE group. And part of what Dr. Proper and I were discussing earlier is really that echocardiographic and hemodynamic endpoints have been the major endpoints cited in these studies offering success, which is encouraging, but it's different than discussing mortality. And an example of that is when looking at the Ultima trial. You can see here, this was a trial, I believe, for the it was for a pharmacomechanical thrombolysis versus heparin alone, and you can see some encouraging outcomes within 24 hours, but really that at about 90 days the RV to LV ratios were exactly the same. So it's hard to know exactly what that means. Are we getting people out of the danger period up front and improving their RV failure earlier while they're in the hospital? That may still be of some benefit, or are we exposing them to risk that doesn't necessarily generate a long-term benefit? It's very hard to say, especially in these massive PE patients that are particularly hard to study. There's also some concerns about whether or not patients get systemic exposure even at the time of catheter-directed thrombolysis. And so at times they can get lumped in terms of their contraindications. And then the one final thing I'll say, just from a technical standpoint, these two bottom options, devices that require particularly large sheaths, really, they can make patients actually sicker at the time of the procedure. If you think about having an acute right ventricular outflow tract obstruction from your big thrombus and you're trying to place a 22 or 26 French sheath into that space, you're actually going to probably worsen the RVOT obstruction acutely while you're treating that patient. So they may need additional hemodynamic support at the time of that therapy. So with those things in mind, it's also important to consider the kind of contemporary data for surgical embolectomy. It's a procedure that probably fell out of favor about a decade ago because of some high mortality, but it was probably not in patients that were most appropriately selected. This is probably the largest series available in the literature, and it's from the Brigham and Women's group, looking at 115 pulmonary embolectomy patients, among whom a significant number were either in cardiogenic shock or requiring CPR at the time of treatment initiation, with a low overall mortality, specifically even within the unstable PE cohort, and very low rates of associated CVA with good 3-year survival. Similarly, this is the algorithm that they offer. It's fairly similar, and then this is a similar series from the Emory group who looked at a smaller cohort, but they did better follow-up probably from an echocardiographic standpoint. They additionally showed very low mortality. That may be some component of selection bias, but at 3-year follow-up, they really only had one patient with even moderate or worse RV dysfunction, and no patients had tricuspid regurgitation that was greater than mild, which can be a surrogate for right ventricular dilation and function. The mean PA systolic pressure was in the moderate pulmonary hypertension range, which is also pertinent. I have a slide about CTEF at the very end, but it's also important to get these people's PA pressures down for their long-term mortality benefit. So with kind of the contrast,
I think really quick, I think that last comment you made is really, really important. And I think that when you talk about any kind of thrombosis of a vein, right? Or pulmonary artery in this case, you're really talking about long-term mortality and long-term disability. And even when you apply the same logic to a DVT, because there's a lot of data now about not using catheter-directed lysis for DVT, what you end up is with post-thrombotic syndrome. Well, post-thrombotic syndrome of a leg is really not that bad. Post-thrombotic syndrome of your pulmonary artery is really bad, and you basically get RV dysfunction. And so my comment being that I think that comment is really important. When I'm looking at a patient deciding should they get pulmonary lysis, my bias is always to yes because of that answer. Meaning we see a lot of patients who get ignored with a main, let's say a single-sided PE, you know they're going to have problems long-term. It's just hard to quantify what those problems are going to be.
Absolutely. And so, so we've talked a lot about kind of that first branch point of decision-making, like Dr. Bowen was mentioning the presence of any absolute contraindications to thrombolytic therapy. And then when considering kind of the benefits and local availability of catheter-directed lysis versus surgical embolectomy, more recent guidelines, both from the AHA and the European Society, really put them more or less on an even playing field. I think, the AHA essentially here does put them on essentially an even playing field in the same guideline statement at a class 2A recommendation. And then actually, excuse me, the surgical embolectomy is actually a class 1 grade C recommendation from the European guidelines. Well, catheter-directed therapy is a 2A guideline just based on the available data. But I think the bias here that I've seen has been to favor catheter-directed lysis. I think that's not unreasonable, but I think consideration really should be given to surgical embolectomy. This is the ACCP guideline that Dr. Proper was talking about, but especially when you're considering kind of just where do you want your sick, unstable patient to be in terms of, allocation of resources, where are they going to be able to get the most adjunctive hemodynamic support, really where are they safest? And sometimes this decision-making comes down to, the frailty of the patient. Are your resources co-located in a hybrid room, or is it like BAMC where they would probably have a decision to go to the IR suite versus OR7 for a surgical embolectomy? And so these things all come into play when kind of deciding which is best for these patients in terms of catheter-directed versus surgical embolectomy. We'll talk a little bit about the specifics of a pulmonary embolectomy. Generally speaking, it's performed through a median sternotomy with bicable cannulation, the SVC and IVC, to completely isolate the right heart. The ascending aorta should be cannulated for inflow, but you don't need to necessarily arrest the heart or perform this under an aortic cross clamp. That can avoid an ischemic period and additional stunning of any RV myocardium or potential injury, which is going to be particularly important when you're trying to wean these patients from bypass as you seek to improve their right ventricular function rapidly and somewhat definitively. Typically, one will start with a longitudinal incision over the main PA that's carried onto the left main pulmonary artery, facilitating removal of any proximal thrombus. You can additionally use balloon tip catheters as shown here for branch vessels, or just extend your incision for further removal under direct visualization. The right PA is then addressed really through a separate incision after fully mobilizing the aorta. Here you can see it's retracted with some umbilical tapes, and actually a modified cerebellar retractor can be placed between the ascending aorta and the SVC to really open this space up. Longitudinal incision here will give you a nice long area of mobility where you can see down into the branches of the right PA, even to extrapericardial segments, and hopefully facilitate sufficient thrombus removal. From there, obviously I'm kind of moving fast, and this article makes it sound simple. One may consider additional flushing of the pulmonary veins. Some express concerns about pulmonary overcirculation during this time, but the pulmonary veins can be accessed through a left atrial incision, or if you have a reason to be within the right atrium for any other reason, like removal of thrombus in transit or removal of a right atrial myxoma, you can take a transeptal approach, access the pulmonary veins with a Foley balloon or another balloon tip catheter and flush, and hopefully be met with this sort of result. But I think this is probably more talked about as opposed to done as an adjunctive technique after you've performed your primary pulmonary artery embolectomy.
Yeah, and just to be clear, you probably would do that just with the cross clamp on, by the way. I know you mentioned,
Okay.
So you made a really, really good point about not wanting to cross clamp somebody just because of, the RV ischemia and I think that's very valuable. I guess my question to you would be, and this is probably a graduate level question, but since you're going to do CT surgery one day, I figure you can humor me and answer it. What would be a consideration? What congenital defects would be a consideration to cross clamp the aorta?
So I would cross clamp if the patient had an ASD or a PFO, and especially if they had thrombus in transit.
Okay, good. So can you explain that to everybody else, why that would be the case?
So for
and explain it from a physiologic standpoint.
So when one is able to access the right heart under bicable cannulation, you really have isolation of the right heart, and any air that's entrained into the heart is not going to make it into the systemic circulation in the absence of a left to right heart shunt, right to left heart shunt. They will go to the lungs. It will be dealt with there. It's really not a risk for systemic embolization. If any patient has a ASD, PFO, or especially thrombus in transit at the time of their pulmonary embolectomy, obviously you want to remove that thrombus and close that communication, but to do so without a cross clamp would entrain a massive amount of air into the left heart and place them at significant risk for air embolism and major stroke. What would prevent that would be occlusion of the ascending aorta with a cross clamp. But that obviously requires a period of myocardial ischemia. Cardioplegia is great, but it's not perfect. And when someone has an already dilated and stunned right ventricle, then weaning them off bypass after the myocardium has been arrested is going to be much more of an ordeal.
Excellent. Yeah, I mean, simply, left atrial pressure classically is going to be higher than your right atrial pressure, but in the setting of a PE, a massive PE, that the shunt across the septal defect, whether it be a PFO or an ASD, can be more pronounced. And as you described, you can actually even have a significant right to left shunt and hypoxia from that, in addition to embolization of whatever clot you have on the right side of the heart to the left side and stroke. So yeah, no, that's really good.
This is kind of the completion picture that one might hope to see. You can see here, your nicely closed pulmonary arteriotomies. The picture here on the right is actually the results of a pulmonary embolectomy that was done here a couple years ago on a young trauma patient who had, I believe, pelvic and long bone orthopedic fractures and periods of SVT and arrest with ROSC with CPR, and was eventually taken for embolectomy after cannulation with VA ECMO. Which dovetails into one of my final slides, which is really the utilization of mechanical circulatory support. There is not a lot of large prospective data out there. This is a small experience from the University of Maryland, who's fairly aggressive with their VA ECMO protocols, but they kind of describe a prospectively maintained database of 20 patients who were cannulated for VA ECMO in the setting of massive PE, and that it really allowed not only for acute stabilization in terms of the availability of biventricular support rapidly, but also the ability to offer kind of a bridge to decision in terms of if these patients were best served with catheter-directed thrombolysis, pulmonary embolectomy, or actually a significant portion of these patients were managed with anticoagulation alone. And they had excellent 90-day survival for what that's worth, although there may be a significant selection bias. But in short, mechanical circulatory support is going to likely be your most rapidly available form of biventricular support in patients that are really kind of crashing and burning. It's an useful adjunct, even for unstable patients who might be headed to the cath lab based on local availability of resources and discussion between treatment teams. And then it does allow for some bridging in terms of allowing for recovery of end organ function and additional hemodynamic support, and potentially additional bridge to decision making for these patients who are acutely ill, and it might not be the best idea to put someone who's in shock liver on a cardiopulmonary bypass machine, but this can buy you time to let their end organ function recover before you dive in.
I think this is kind of the new wave, and I think this is at SAMC something that, I mean, we don't see a lot of massive PEs, but in general, ECMO has really matured, obviously, at SAMC far greater than most institutions. And so the ability to get on ECMO very quick is there. I really think that ECMO as a bridge is brilliant. And the reason I say that is the time it can buy you, as you mentioned, is really important. But I actually think you can do ECMO with catheter-directed lysis. And so you can almost give the patient a test of catheter-directed lysis. And it doesn't really matter where the ECMO cannulas go. The PA can be accessed either through the jug or through a different femoral site. And so I would say, at SAMC in particular, where ECMO is kind of readily used, this is probably a great discussion point. And the other comment I would make about lysis versus pulmonary embolectomy, I'm actually a big sort of fan in general of the idea of pulmonary embolectomy. But what you'll see clinically in most of these patients is that they are really teetering on the edge when you meet them in the ER. And the last thing you really want to do is intubate them if you can help it. And so catheter-directed lysis, I have never done catheter-directed lysis on a intubated patient. Now, I haven't done tons of them. I've probably done about 10 total in my entire career, but they're always awake and they're always on BiPAP. And then usually with catheter-directed lysis, if it's done well and they're a reasonable candidate, they'll come off high flow oxygen usually within 24 hours. Because usually you'll prime the catheters with 5 or 7 milligrams of TPA. So they get an initial jolt right into the PA. But pulmonary embolectomy, in my mind, is a great operation. It's not one that I can do, but it does come with some significant upfront risk of just going to sleep. And I think in general, some of the results that are published don't take into account the centers that it's happening at. And so I don't know that they're really translatable to smaller centers without the technical and anesthesia support. You mentioned an Emory center. Well, they do a lot of hearts at Emory. So again, if there's data from smaller centers, but PEs present a lot of times in the small community hospitals, and there I think catheter-directed lysis is usually safer because they don't have the cardiac expertise and the anesthesia expertise.
Absolutely. One last point about the differences between pulmonary embolectomy and pulmonary thromboendarterectomy. These are two completely different operations. One is for acute PE, the other is for chronic thromboembolic pulmonary hypertension. You can see obviously these specimens are very different, acute clot versus chronic clot. The point that I use this slide to make is really that submassive and massive PE patients are at approximately 10 to 15-fold risk for development of CTEPH. And that risk is directly related to their PA systolic pressure at the time of PE diagnosis. And that follow-up echocardiography within about 6 months of hospital discharge should really be mandatory for these patients, and it's a key part of their follow-up care. That is my last slide, and I may kind of get going. There was a major trauma that was just paged out, but for those interested, to Dr. Proper's point about kind of the cross-sectional landscape of pulmonary embolectomy, this is an additional recent publication in the Annals of Thoracic Surgery using the STS database and really looking at what is kind of the current state of pulmonary embolectomy. I didn't have a great place to put this into my talk, but this is probably the most contemporary data looking at all centers. And to your point, Dr. Proper, you can see that the vast majority of centers are performing 2 or fewer cases per year. It's something that is widespread. It's impossible to really kind of co-locate these patients based on the nature of their disease. But I can maybe take any questions or comments, but otherwise I'm probably going to run down to the emergency department.
Hey, Alex, quick question. So I may have missed this, but like at first you were saying if they have a contraindication to systemic TPA, then you go down the road of pulmonary embolectomy or open surgery. If a patient comes off the street into BAMC's ER, we have, it's 3 p.m. or whatever, everybody's around. You have the ability to do anything you want. What's the first choice?
So the first choice would be an assessment, really, if they have any contraindications to systemic lysis.
There you
If they
go.
do not, then according to the guidelines, the first choice would be systemic lysis.
But a
And
center that has the ability to do directed lysis, would you do that, or do you still think systemic lysis is better?
I think that depends partly on exactly how the patient looks, and I know that's kind of equivocating. If they have a large central thrombus, they're kind of teetering on that edge between submassive and massive. That patient might actually be better served, in my opinion, with catheter directed versus systemic lysis. If that patient is crashing and burning, and you think that they are not going to survive without some treatment for more than a couple hours, then that would honestly be someone that I would favor lysis in the ER and potentially the adjunctive support of ECMO.
Just don't withhold systemic lysis, right? Because there's always a decision-making time. So even if you have catheter-directed thrombolysis 20 minutes away, the half-life of TPA is 45 minutes. Maybe you don't give 50 or 100 milligrams. Maybe you just give 25 milligrams. That's a clinical decision. But the book answer is what you said: 50 milligrams IV push of TPA, or IV piggyback, however they do it, of TPA in the ER. Giving 50 milligrams of TPA should not make somebody unwilling to do catheter-directed thrombolysis on them, because it's literally a vein puncture. It's not an arterial puncture. You can access the saphenous vein. You don't really need big sheaths in these cases. You can need 6 French sheaths nowadays. So you should always give systemic if you think someone's dying in front of you. And even if you think they are really in bad shape but aren't dying right in front of you, but you're going to go, still give it. If you've made the decision they need lysis, give them lysis. Don't withhold lysis. But don't give them a huge bolus of heparin and a huge bolus of TPA together. That will almost certainly increase their risk of bleeding.
So do people talk about like a stepwise approach where you give a little bit of systemic, then you go for catheter, and then if they're still not better in 12 hours, then you have to do
No, because those talks
not really, but
those talks only happen at places like SAMC and Emory and Cleveland Clinic, where you have all options on the table. That's not how most patients present. So at SAMC, you can do whatever you want. I mean, I think you guys should go balls out on ECMO for any of these patients. And because you'll have Denel, you'll have vascular, you'll have IR, you have everything. However, that's not the reality. And so the chest guidelines are written to make sure that most patients in the country receive the appropriate care. And so, they're just guidelines. At SAMC, you don't have to follow them, but if you're not following them, you should have a good sense of why you're not following them. And so if you said, okay, we can get in the cath lab within 30 minutes and have a catheter up in the PA, okay, withhold lysis. That's not a big deal. 30 minutes, give them some heparin and just wait. But you're going to give less overall TPA with catheter-directed lysis than with systemic lysis. Because most of the time you're going to run 2 catheters at 1 milligram an hour. And usually within 12 hours, you're off TPA. So it's, if you have a patient with a relative contraindication of TPA, then catheter-directed lysis is favorable because you can run less TPA and still get a benefit. And remember, absolute contraindications to me are cerebral hemorrhage and eyeball hemorrhage. But when you have a patient dying, everything else is relative, because most other bleeding you can stop surgically. Someone just had a thyroidectomy and they come in with a PE, okay, open their neck if they start to bleed.
Right.
Mm-hmm.
I agree.
But the only other comments, I know I'm sort of leaving, but this has been a topic of discussion. IR is pretty interested in pulmonary lysis. I personally think that vascular should be more interested than we are. They always come in at 2 a.m. They never come in at 2 p.m. That's sort of ubiquitous, which is why people don't like being on the PERT team. At other institutions, when I've been involved with PERT teams, it's always best served to have a vascular surgeon, a cardiac surgeon, and a pulmonologist. And then you have a 3-way decision that what the patient needs. I've never met a cardiac surgeon yet who's overly excited about going to pulmonary embolectomy in a patient that's presenting acutely an RV failure. They always would rather usually try something first.
Yeah, I'm giving more.
So that there's a failure. Yeah, you
Agreed.
gotta go to your thing, dude. So, actually, if you gotta go to the ER, you can, man. Don't. Anyway, I think at SAMC that would be the tact I would take, is have cardiac, vascular, IR, pulm, and then I would also have the ECMO team. And I think you'd have a great PERT team.
I think that was a good talk. I don't know who's still on this call, but I think that was good for 30 minutes. I mean, I think the big thing, and I think Dr. Proper was kind of highlighting it earlier, you know, we have everything here, but, you know, at other institutions, I think one of the big problems is delays, and the idea that you, you know, need to get this patient to a center of, you know, of excellence. I've never done a surgical pulmonary embolectomy, to be quite honest. We did one, I think Dr. Sparks and Dr. Graham did one a few years ago, and the patient had a good outcome from that. There's actually data that says that when you delay to send it to a place where there's a higher volume surgeon that's done it, that patients still do worse, because, and I think it's really the crux of it is that you're delaying patient care. And so I think to that point, even delaying to do some kind of catheter directed therapy versus, you know what I mean, systemic thrombolysis, you know, you got to weigh those options. And if it's going to take 4 hours for somebody to get in to do catheter directed thrombolysis, then I'm not sure that's a better call than you know, systemic thrombolysis up front. And so I think that's the kind of the point is these folks they don't have much reserve, and once they kind of get in that cycle of shock, it just perpetuates itself. You know what I mean? So once your LV starts to fail, then, you know, coronary perfusion drops, and then the RV's now ischemic from that as well. So I mean, it's just this repetitive cycle of, you know, so these folks don't do well in a short period of time. And if they die, you know, if they arrest, then the outcomes are even worse. And so, you know, you can try to rescue these folks with ECMO, but the mortality is really high at that point.
From a thought process standpoint, if you're like a resident, the way you can kind of think about these interventions, if you compare it to something like ED thoracotomy. So ED thoracotomy is sort of the equivalent of pulmonary embolectomy. It's a more invasive procedure. When it's done well, it works really, really well. And for the most part, there's expertise, particularly in our institution, to do it well. You can think of catheter-directed lysis like Reboa. This is like your hope that you can put something in and stop some hemorrhage so you can go do a definitive repair, or that you can just stop the bleeding. And then TPA is like fluid, right? You're going to give fluid to get their blood pressure back up. You're going to give TPA to try and remove some of the clot. The only difference is that most of the time, TPA alone actually has a much better chance of working than fluid does with hemorrhage. If you kind of think of them in a graduated system of interventions, and it doesn't necessarily mean you're not going to do two together, right? You might put in a Reboa and give fluid. You might do an ED thoracotomy and give fluid. So those are kind of the comments I would make. The only thing is, you know, again, when you start opening someone's chest after 100 milligrams of TPA, there's going to be bleeding. But again, it's 45 minutes, 60 minutes. These patients are all dying. I mean, so the intervention you're doing, when you talk about, you know, people need to be more aggressive at giving TPA and more aggressive at catheter-directed lysis, because the outcome is really bad if you don't. And someone being a pulmonary cripple, in my world, is not really a good way to live. And so, you know, we hear all the time, like, oh, they had a colectomy 6 weeks ago. Well, who cares? You know, that bleeding can be stopped. They're not going to bleed from 6-week-old colectomy. Again, brain and eyes, those are the two that really kind of get me going in terms of contraindication.